Welcome to EASL Studio, your weekly hepatology broadcast news. In this episode, we'll be discussing liver disease policies and why this should matter to the World Health Organization and other United Nations agencies. If you're not from the world of hepatology, you might be wondering, what is steatotic liver disease? And how come I never heard of MASLD and MASH if they're so common? Firstly, steatotic liver disease has replaced the term fatty liver disease and is now used widely around the world after a global consensus was achieved in 2023. MASLD is metabolic dysfunction-associated steatotic liver disease, which in brief means you have too much fat in your liver, called steatosis, and it was not caused by excessive alcohol use. It can lead to MASH, or metabolic dysfunction-associated steatohepatitis, and can lead to liver fibrosis, the most important predictor of poor health outcomes due to liver disease. But it's really important for you to know that MASLD is the most prevalent liver disease in history, with more than 1 in 3 adults around the world estimated to have this disease, and more than 1 in 10 children. In addition to MASH and liver fibrosis, MASLD can lead to cirrhosis and hepatocellular carcinoma. It can require a liver transplant and can result in death. Today, we want to discuss how we can end this public health threat. My name is Jeffrey Lazarus. I'm a professor of global health at the CUNY Graduate School of Public Health and Health Policy in New York City, and a research professor at the Barcelona Institute for Global Health in Spain. I also chair the Healthy Livers, Healthy Lives Coalition, made up of AASLD in the US, ALE in Latin America, APASL in Asia, EASL in Europe, and SOLDA in Africa. I'm joined by Professor Shira Zelber-Sagi, the chair of the EASL Public Health and Policy Committee. She's also a full professor of health at the Haifa School of Public Health in Israel. Dr. Mazen Noureddin is one of the world's leading experts on MASLD and MASH and is chair of the AASLD Special Interest Group on MASLD and is a professor of medicine and a transplant hepatologist at Houston Methodist in Texas. Dr. Kremlin Wickramasinghe is the regional advisor at WHO Europe on nutrition, physical activity, and obesity. Welcome. Thank you very much for joining this session. And I'd like to start off by asking you, Mazen, 2023 was a turning point for the field with the adoption of a new nomenclature that gave us SLD, MASLD, MASH, and MET-ALD. We went from being almost exclusively disease-centric to increasingly people-centric. But tell us why this year, 2024, has been so important for people living with MASH and fibrosis.
Jeff, thank you for having me here. Howdy from Texas. And this year is special in multiple aspects, but the most important one this year is the first FDA drug approval of medications for MASH with significant and advanced fibrosis. As you know, like this disease management is very important as a holistic approach, and diet and exercise, which Shira worked on extensively, are the backbone of the therapy. But we also needed to add interventional with pharmacological therapies, and that happened this year. Also, the pipeline of MASH with significant advanced fibrosis is very rich, and we expect that many medications will be approved in the next few years and will help our patients in addition to diet and exercise with MASH directed therapies. So it's an exciting year in that aspect in particular.
Thanks, Mazen. I agree. 2024 holds so much potential, and we've already seen so many exciting developments. Now, Shira, you're a professor of public health, and we often refer to MASLD and MASH as a public health issue or even a major public health issue. So let me start off by asking you, how can we define public health?
So public health is really important in the field of all non-communicable diseases, and definitely in the field of MASLD. So the classic definition of public health is the science and art of preventing diseases, prolonging life, and also promoting health. And it's done through organized efforts of society, different organizations, communities, and individuals. And in fact, the basis of public health is the ability to analyze the determinants of health, including commercial determinants and social determinants of health, and to learn what are the threats that the society faces in terms of health and how we can overcome these threats. And what is really nice about public health is the fact that this is an interdisciplinary or even transdisciplinary field that involves many experts from many disciplines, including epidemiology, biostatistics, social sciences, management of health services, mental health, behavioral health, nutrition, and more. And this approach is extremely important when we want to deal with liver health.
Yeah. So, Kremlin, some of us call steatotic liver disease, including MASLD and MASH, a public health threat. And this is language that the World Health Organization, where you work, has used to describe viral hepatitis in their global health sector strategy in 2016. Do you think it's accurate for us to call steatotic liver disease a public health threat? And really, how does WHO define what a threat is?
Thank you, Jeff. Thank you. It's really nice to be here. And yes, I think you correctly took one example, hepatitis or virus. So anything that we have statistical information, looking at the data that causes a health deterioration or impact on our health is a threat for the health. And mainly to come to that, we need to look at the data and convincingly that particular exposure causes that health outcomes. So with that evidence, experts look at it and look at what are those threats and what measures we need to tackle them depending on the nature of that and how it spreads. So of course, here with your introduction, you talk about the statistics, current burden of the steatotic liver diseases for adult and children. I think that itself tells us some of those statistics you share is much larger and wider than some of the other diseases that we are currently dealing with. So clearly, it's timely that you are bringing up this dialogue and really raising the awareness to bring the public health community and the global health community to discuss and have the dialogue to take actions.
Well, thank you for explaining that. So what I understand is you need to see the prevalence data, the human burden, as well as the economic burden, and then be able to take, based on the evidence, a decision that it's a threat. Is that right?
Yes, I think as I mentioned, there are committees set up to look at new diseases, emerging diseases, whether it is a disease, what is the exposure, or what kind of threat and impact it has on humans. So those committees look at them. But more importantly, as you know, that all diseases are important. So in ICD classifications and our data, we look at all health statistics from hospitals. But if you are asking about how to take it higher up on the agenda, yes, therefore, countries will look at data and decide at our governing body meetings, this is a major problem for our region or our world, and we need to, as a global community, using World Health Organization as a platform, need to come together and come with a plan to prevent and manage or tackle that disease. And that needs a decision from our governing bodies to take it up to that level.
Thank you. So one take-home message there I'm hearing is the importance of the International Classification of Diseases, ICD, and that we actually use the right coding. And, Mazen, you're working in a hospital and, you're using ICD. As a clinician, you're seeing patients, you're running clinical trials. But how concerned are you about liver policy issues at that, let's say, the higher level outside of the hospital?
I mean, I agree with you guys, and I'm concerned. And let me give you the perfect example, Jeff. Hepatitis C. We had treatments many years ago that with antiviral therapy, 3 months, you can get SVR, which a lot of people considered as the cure. But estimates now say we have about 50 million people are undiagnosed, and MASH is even more prevalent in the world. So if you look at the hepatitis C and what happened with it over the years, those that they had policies, they were very successful. And examples are Egypt, Spain, and other countries. So those countries that they put policies in place, they were successful in treating hepatitis C. Egypt had a very high prevalence, and they did very, very well because of that. So we need these policies to find the patients, diagnose them, link them to hospital care, and even link them to the care in the community. So it's extremely important, Jeff.
Thank you. Thanks for presenting the HCV example. Even in countries that have a good policy for testing, like the US, those policies also need to be implemented. But without that top-down approach, it makes your work and everybody's work a lot harder. And the result is people, living with these diseases don't get diagnosed and don't get linked to care and don't get the treatment they need. Now, Shira, you're on the EASL governing board and know that associations have taken on the alcohol, tobacco, and food industries to varying success. I'm wondering, should liver associations join these efforts, or should we focus on improved treatment and care at the more clinical level and sort of liver-specific policies?
So the short answer would be we should do both, of course. And you know that EASL is investing a lot in clinical care and in clinical practice guidelines, which is essential. But the thing is that we can't stop there. We need to do more. We need to reach a greater audience, not just the known liver disease patients or the advanced liver disease patients. And there are two specific things about liver disease that makes it even more crucial. So the first thing is that usually liver disease, especially MASLD, is discovered in a late stage where there is advanced liver disease and the patient approaches the physician. And in that stage, we do not necessarily have the ability to change the courses of the disease as much as we want. And it is also very costly, the treatment in that stage. So we want actually to do more. We want to do primary prevention. We want to prevent a disease occurrence. These are preventable diseases, and we can do it by awareness, education, and lifestyle modification. And we can reach younger population. We can reach young people, even children, and have prevention, and not to wait that these children will develop liver disease and get to the physician, to the pathologist. So this is one point. The other point is that we put a lot of responsibility on the patients. We tell them to change their lifestyle, to avoid alcohol consumption, to stop smoking. And this is a very heavy responsibility, and it also leads to stigma. And we need to shift the responsibility not only on the patients, but on the society. We should make changes in the society, in the policy, in the environment to help people with liver disease or at risk for liver disease have a healthy lifestyle.
That sounds like if we're going to shift the responsibility, we also need to take on some of those industries that are targeting those with, more challenging lifestyles, children who aren't always able to take, the right decisions. They're getting addicted on alcohol and food. So targeting those industries is probably important for liver associations. Am I hearing that correctly?
Yes, it's crucial. Those commercial determinants of health, we have to deal with them. We don't only have a role as in the clinic. We have a broader role. We need to change the social determinants and the commercial determinants of health if we really want to prevent liver disease and reduce liver disease burden.
Right. And there are some countries, some associations, some cities taking that on. If we have time, we'll come back to that. But I'm wondering, Mazen, what AASLD, the American Association for the Study of Liver Disease, is doing, in this regard.
Well, Jeff, as you know, the AASLD work closely with EASL, ALA, and implementing the nomenclature through a very thorough process. So that has been done already. And now after that, they worked very hard on implementation. So that's a very broad and a lot of work behind the scene. But we can summarize it quickly. So the implementation included meeting with government agencies, and have been in some of these meetings where we met with the VA, the NIH to implement this, patients advocacy group to help them understand what is this and how they can transmit this to the other patients. ICD coding, changing guidelines, working with other societies, and extending into other organizations beyond liver, such as endocrinology and obesity. So a lot of work has been done behind the scene, also in United Nations levels and World Health Organization, along with HLHL as well as EASL. So I can't summarize it in a minute, but a lot of work has been done by many organizations, including the governing board of ASLD, their staff, as well as EASL and others.
Thank you. And I know that, being in the US, there are many organizations taking on these industries. So you have a great set of allies with a really robust, community and non-governmental effort. Now, Kremlin, my guess is that many people at WHO don't know what SLD, steatotic liver disease, MASLD, or MASH are, not to mention MET-ALD. How can we quickly raise awareness at WHO offices around the world and the member states they serve?
I think that, as you said, you need to have a community who's advocating for it, raise awareness, and create that dialogue. So, starting point is a clear definition and a classification. Once you have ICD code, that start generating data. Once you have consistent data from countries, you can produce graphics and graphs comparing that disease burden in neighboring countries, regions, and globally, which will spark the discussions for similarities or differences. And together with professional association, right, EASL and others, and public health community, we should organize policy dialogues, discussions about the disease burden, but also policies for both prevention and management, and current level of implementation and the challenges for implementation. But I think one way to bring that connection and knowledge is starting from the other end. But listening to you, especially for the prevention part, it's very clear the policies that you are interested for prevention are the same policies that many other WHO officers, many other public health experts, government ministries of health and ministers want to tackle to improve diet, to increase physical activity, create healthy environment for children, families, and everyone communities. And they will engage with that. That's an easy starting point. And from that, you can take them to show that it also helps not only diabetes, cardiovascular disease, and cancer, but also a disease that affects this many of the adults and children. And that way, you are very inclusive. You are not competing with anyone for those prevention policies. I was very happy to hear from Mazen about the implementation of policies. I think that's the other area. It's not only advocating for it, how you can support implementation of policies. We know when we wanted to implement sugar taxation, the advocacy of endocrinologists, doctors who are seeing and daily treating diabetic patients, really did the main advocacy for successful implementation. They see the burden that families, patients go through due to diabetes. They advocated the need to change our pricing for high sugar products. And their advocacy really gave the power for governments to raise taxes for sugary drinks and support that implementation. So you also, the clinicians, have a huge role here to use their advocacy power to support policy implementation.
Thank you. It was interesting just reading in New York City, where there's an amazing strategy called Healthy NYC to extend life expectancy to 83, real tangible goals for concrete goals for diabetes, no mention of MASLD and MASH, but they did, just implement here this month a sugar tax after a long struggle. And that Shira is a front of package label for a certain number of grams of sugar in sold in certain kinds of outlets, fast food outlets. So it is possible. And of course, now the population needs to understand what that means, and clinicians need to say, when you see that symbol, it means there's a lot of sugar, and you should really think twice before you purchase and consume it. So Mazen, Kremlin was talking about how at the policy level we can have that kind of collaboration across disciplines, and Shira already mentioned that public health is by nature multidisciplinary. So you mentioned the new nomenclature, which includes metabolic dysfunction. So how can we create collaborative opportunities, at the clinical level as well? What kinds of things are happening in hospitals? Is it still very siloed, or is the new nomenclature opening up doors?
Yeah, I just want to comment quickly on sugar taxation. It makes me actually feel happy that I'm doing the right thing with my children. A lot of times we feel like we're too strict or doing it wrong in compared to other people, especially in Texas. But anyways, I think we already started seeing stuff. We need to engage the endocrinologist, hospital administration, streamline the reimbursements, apply the ICD codes, but also we're starting seeing, especially under the umbrella of metabolic, collaborative efforts with other societies. We have now been in meetings with American Diabetes Association, EASL. I was there in Madrid last week, and we have seen a lot of heavy liver sessions. So those are important efforts and collaboration with other societies. And now it's bringing many organizations together. The EASL guidelines was done with the ASDs. So these kind of efforts that we really need to see.
Right. Yeah, you mentioned the new EASL guidelines in collaboration with European Diabetes and Obesity Association. So that's a fantastic development, a way to really build the community of practice. So Kremlin, and you've heard about the high prevalence of MASLD, and you've explained to us why it's not yet really addressed by WHO. I'm wondering, now, as Mazen described, there's a specific treatment for MASH. It's right now available in the US. We're hoping for approval soon in Europe. But is this, Kremlin, really an issue that should only concern high-income countries, or should lower and middle-income countries also be concerned about MASLD and MASH? Or do they just have so many other issues that this is lower on the list?
No, I think all the data shows that it's a problem for low and middle income countries as well, not only high income countries. It's a global issue. I think we all agree. But also, specifically, the prevention part, if the treatment is expensive, that's exactly why we should work as a global community to bring the prevention policies which will protect everyone, regardless of their socioeconomic status or ability to pay for treatment. So the prevention policies you are talking about, either to improve nutrition, obesity prevention, those policies we have are across for low and middle income countries and high income countries. We have same recommendations based on the cost effectiveness. So the policies that work here will work in low and middle income countries. So they can take action on the prevention now, and it should be a global dialogue with all countries, and it should make sure that we keep involving low and middle income countries as well.
Thank you. And Shira, very high level, what can the liver societies do to have, to help us have better policies addressing the social and commercial determinants of health that you already mentioned? Thinking, specifically around what would improve liver health outcomes or prevention.
So we see really growing efforts of liver associations in public health and advocacy. And one of the main topics are social and commercial determinants of health, because it is very clear that there are health inequities in liver disease. It doesn't distribute equally in different populations. Liver disease affects worse prevalence and worse outcomes, the low socioeconomic parts of the society, and they are exposed to aggressive marketing of unhealthy products like alcohol, tobacco, sugar beverages, ultra-processed food. And in addition, they have food insecurity and lower ability to purchase healthy foods. So definitely, we need, as an EASL, and with collaboration with other associations, we need to increase the awareness of the harmful effect of commercial and social determinants of health, and to give more efforts to help these populations to avoid the leading hepatic risk factors. And as EASL, as an association, sees several roles in dealing with this topic. So the first thing is, as I said, increasing awareness. The second thing is showing evidence, is using the science that we know to do. to do advocacy. So for example, EASL recently published the HEPA Health 2 study, which shows by prediction models that if you apply policies of alcohol consumption and on sugar beverages consumption, you can reduce significantly the burden of liver disease mortality and liver cancer. We also do advocacy through scientific publication like the EASL Lancet Commission, which focuses on prevention and on commercial and social determinants of health. We have policy statements on alcohol and food, and we also have a policy statement addressing the issue of migrant health, which really is important because we want to deal with the population which have the lower abilities to have a healthy lifestyle, and see how we can assist them and support them. And one last issue is collaboration. EASL has a lot of collaboration with WHO, with other associations like the Healthy Liver, Healthy Life. We try to outreach the community by different projects like Love Your Liver during the EASL conferences to have education and activities with the local communities. And I just want to say that remember that we are stronger together, and we have to work all the different associations together, and WHO and other organizations, and always involve the patients' organizations.
Jeff, can I add something to what
So-
Shira mentioned on commercial determinants?
Sorry?
Yeah, so I think that's really important. Thank you, Shira, for mentioning the commercial determinants. We find the biggest barrier for implementation of those public health policies, especially related to nutrition and obesity, is commercial determinants. And this has been documented. We know evidence from WHO has not changed in the last 10 years. The recommendations or the policy recommendations we are telling to countries to address nutrition or obesity is exactly the same what we said in 2010. But when we ask from government officers, why couldn't we implement this in countries successfully? One of the highest issues is commercial determinants. And one way we could change that shift is the advocacy from clinicians who are seeing these patients and who are seeing the impact of these commercial actions on people's daily living and their suffering. And another area is the recognition of conflict of interest. I think we all know that tobacco industry cannot come to Ministry of Health and have a meeting. That's clear. But when it's come to food, it's something we need to eat. We can't completely say no to food. So where do you find that balance is a challenge, but we need to build our capacity in clinicians, in hospital managers, in ministries of health and governments to recognize conflict of interest and manage conflict of interest. And that's become crucial. When you talk about nutrition promotion, we want to get our house in order. So we say first we should give a healthy diet in the hospital for the patients. Similarly, when we talk about commercial determinants, first thing we should do is start with our own hospital, start with our Ministry of Health, then go to the government and others. So if we learn that as a community, we will spread it and build the capacity together.
I completely agree.
So in a way, many of the answers are in plain sight. You've said that for over 15 years, you've been promoting the same kinds of policies, but there have been some important new developments, both with the approval at the World Health Assembly asking WHO to develop what are called best buys. Can you tell us, Kremlin, briefly, what are these WHO best buys and why are they important?
Thank you, Jeff. So when world leaders met at UN at a high-level meeting to tackle NCDs, as you can imagine, there are so many actions. If we ask around experts what we should do to tackle NCDs, there'll be 100, 200 actions. So one common sense is, where do we start? What are the most cost-effective intervention for a low and middle income country to confidently invest in their resources to implement? So from World Health Assembly, the countries, our governing body, asked WHO to review different interventions and tells which one are the most cost effective with least amount of money, giving the best health outcome. And then those are best buys. And the next layer we call good buys. So we use different cutoffs. Okay, if we can get one DALY, disability registered life year, for $100, what is it? If it is 100 to 1,000, what it is. So we look at different levels, especially with the focus on low and middle income countries. So we categorize different intervention and then we provide it to the World Health Assembly. They review it, they approve. So we have set of intervention which we can confidently say these are cost effective. You can confidently pick from this list to intervene. So for other diseases, diabetes, cardiovascular disease, cancer, alcohol, nutrition, for each area, we have those set of recommended best buys and good buys based on the cost effectiveness of those interventions.
Thank you for explaining that. I think the work WHO has done on Best Buys is amazing, and really a lot of it is very relevant for us in the liver field. You already mentioned around alcohol. Really, many of the Best Buys, for diabetes and cancer, can also be applied to many liver diseases. But each of those major NCDs at WHO, COPD, cancer, diabetes, cardiovascular disease, has disease-specific best buys, and that's really one of the things we're going to need for MASLD MASH, for steatotic liver disease more broadly. So Mazen, we're coming to an end of this episode of the EASL Studio, and I want you to please fast forward 5 years. Imagine we're closing in on the magic year of 2030, when the Sustainable Development Goals should be achieved. These are the goals that all UN member states have agreed to. So what would good look like to you in terms of MASLD and MASH policies?
I'll make it simple and short, Jeff, as a physician. Within 5 years, I would like to see patients being diagnosed through efforts that you guys are talking about, policies. We did not mention the FIB4 test, for instance. It's a cheap test that it's a blood test there with age, and you can identify your patients. We have implemented that in guidelines. The ASLD, EASL keep educating people and pushing for it. I would like to see policies where there's this is standard of care connected to reimbursement, connected to quality, and then all physicians are doing it. Our patients are being identified and then being sent to the physicians to screen them for the disease, diagnose cirrhosis, screen for cancer, and more importantly, treat them, because we have medications in addition to weight loss and exercise. So all these efforts that are ongoing by ASLD, EASLs, and others are welcome, and I welcome our partnerships with WHO, UN, and I hope that will lead to stronger implementation of these policies and making sure our patients are okay.
Thank you. So 2030, hopefully even sooner, a world where everyone with MASLD knows they have this disease and is getting the appropriate treatment and care. Kremlin, last question, very short answer. So the issue of liver disease is really not just only about the World Health Organization in terms of global policies, even if you are the leading health agency in the world. So as we expand the community of practice and seek to engage other multilateral institutions, UN agencies, which ones would you suggest that we engage with?
I think we should start with the community's patients and then go into their own governments. And then through that, government should start advocating for that and talking about it as a problem at their region and globally at the World Health Organization. And you mentioned all the professional associations related to other diseases and other public health associations, to name a few.
Great, thank you. So public health associations, other UN agencies, we need to start figuring out who also to engage in, although we're really grateful for the collaboration we've had with you and other WHO experts and offices. So I'd like to thank you, the three panelists, Kremlin, Shira, and Mazen, for your reflections on how we can draw attention at the highest policy levels to the most prevalent liver disease in history, metabolic dysfunction-associated steatotic liver disease, or MASLD. The members of the Healthy Livers, Healthy Lives Coalition, ASLD, ALE, Apostle, EASL, and SOLDA, will keep banging on the drum along with our partners from around the world, be they national hepatology or endocrinology associations, or patient advocates and public health associations, so that we can achieve at least parity the same level of importance as other major NCDs like diabetes, cardiovascular disease, cancer, and chronic respiratory diseases, all of which are well addressed by the World Health Organization and will be included at the United Nations high-level meeting, the fourth HLM, on NCDs in September 2025, and are in WHO technical guidance and strategy documents. Places MASLD, MASH, steatotic liver disease needs to also be included. So again, thank you for your insights, and thank you to everyone out there for listening. Please share this discussion and join us in ending the steatotic liver disease public health threat. And join us again at the EASL Studio on November 13th for an insightful discussion on the new clinical practice guidelines for liver transplantation. And don't forget to become a member and be part of the EASL family. Thank you.